This episode of the Curbsiders is sponsored by ACP's Internal Medicine Meeting 2019. This is the premier live clinical and practice-related education meeting for internists and subspecialists. It's taking place from April 11th to 13th, 2019 at the Pennsylvania Convention Center here in my hometown of Philadelphia, Pennsylvania. I can tell you that I am super excited for this meeting. I was there last year and I will be there this year with my Curbsiders co-hosts, and I can't wait to get back together with all our internist friends from around the country. We really hope to see you there.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders, and Stuart is not here tonight again, Paul, but we'll get by.
Matt. There we go. How'd that feel?
Felt great.
Great. Good
I
stuff.
was still talking when you said it, so it kind of feels like Stuart's here, but you know. And with us tonight, Paul, is returning co-host Dr. Justin Lee Burke.
Hello.
Paul, before we start talking about the specifics of tonight's show, can you remind people what it is we generally do on the Curbsiders?
Delighted to, as always, Matt. We are the internal medicine podcast, and we use expert interviews to bring you clinical pearls and practice-changing knowledge. We often spend the first portion of the show getting to know our guests a little bit and hearing what they do to decompress, but if that kind of thing you find less helpful, I guess you could skip ahead if you wanted to, and you can look at the timestamps in the show notes to do so.
Justin, why don't you tell the audience a little bit about the show tonight? And I think we had forgotten some information that we wanted to insert into the show at this point.
Sure. So we have a great show tonight on sickle cell disease, the primary care of patients with sickle cell disease, and addressing all of the complications as they arise in the hospital, a good portion of them. One of the things that we talk about is the genetics of sickle cell disease. And so a quick review of the structure of hemoglobin. We're all born with two hemoglobin genes. The typical hemoglobin genes are A and A, which is what you typically find in a healthy patient. Of note, when you are first born, one of the hemoglobin genes is F, or fetal hemoglobin, which we talk about later in the setting of hydroxyurea. There are other hemoglobinopathies, or changes in these genes, that can be found in beta thalassemia, alpha thalassemia. You can have hemoglobin C trait, or in the case of tonight's episode, we'll talk about the S gene, where the SS mutations are what make up sickle cell disease. The S mutation with a normal A make up sickle cell trait, and then you can also have other genes, genotypes of sickle cell disease that we'll talk about throughout the show.
I think that's a great overview. Thank you, Justin. I certainly needed that overview. So
the audience used that about 2 hours ago.
Okay, so our wonderful guest for tonight's episode is Dr. Sophie Lanzkron. She is an associate professor of medicine and oncology in the Division of Hematology at Johns Hopkins University School of Medicine, and is the director of the Sickle Cell Center for Adults at Johns Hopkins. It delivers state-of-the-art, multidisciplinary care to over 500 patients. She is internationally recognized for her pioneering research on the optimal care and management of patients with sickle cell disease. She has served on the National Institutes of Health expert panel in the management of sickle cell disease and serves on the American Society for Hematology Sickle Cell Guideline panel. Her research focuses on improving the quality of care provided to this historically underserved population, and the Johns Hopkins Sickle Cell Infusion Center, which opened in 2008, provides urgent care to patients in crisis so that they can bypass the emergency department. This remarkable innovation has led to numerous improvements, including decreases in admissions, 30-day readmissions, and most importantly, rapid relief of pain in a patient-centered environment. This innovative model of care is currently being emulated throughout the country. Needless to say, we are thrilled to feature Dr. Lanzkron on the show. So without further ado, here's our interview. Sophie, the first question that we always like to ask our guests is, can you give a one-liner to describe yourself and include something about yourself outside of what you do as a physician?
Sure. So I am an adult hematologist, and I really enjoy taking care of adults with sickle cell disease. I am married to a nephrologist, and so we have really great dinner conversation. And we have two teenage boys and are newly empty nesters, so life is good.
Okay. So the dinner conversations, based on the pre-recording, you're talking about urine-specific gravity. You were for a peek behind the curtain for the audience. It's fascinating conversation.
a lot of patients, whether my husband used to do medicine, and he'd have patients with hematologic disorders who are bleeding. And so my poor children, they know terms like bleeding out and all sorts of exciting conversation we have over the dinner table.
Wonderful.
Yeah, you're left speechless by this, I see, yeah.
Not that different from William's holiday conversations, and there are actually no doctors in my family. We end up talking about bleeding out regardless.
Yeah, so fun.
We're going to switch things up. I'm going to ask you, tell me about a movie that you've recently enjoyed, or even your favorite movie, if you are feeling brave enough to even answer that question.
Oh, yeah, no problem there. My favorite movie is Fever Pitch. Fever Pitch. You don't know. Fever Pitch is the story of love story of the Boston Red Sox. So it was filmed. I grew up right outside of Boston and grew up with the Red Sox being like just pathetic my whole life until 2004. And Fever Pitch was filmed that year, and they didn't know how the season was going to end. And it's just a great movie, especially if you happen to be a Red Sox fan.
I imagine that would amplify the experience a lot.
I was there. I was in college at the time, and it was very exciting in Kenmore Square. I was in Kenmore Square at the for the whole playoffs and the World Series. My gosh, I'm lucky I'm alive.
It was awesome. It's just awesome.
So my question is, can you talk about some of the best advice you've ever received as a learner or someone in the field of medicine?
I think the best advice I got was never say never and never say always. And I think that really rings true every day when you practice medicine and in most of the things you do in life.
And one more question. What level are you on Pokemon Go?
Really? I did mention the two boys and the husband. So I am level 34, if you must know.
It's amazing.
Yeah, it is. It's amazing when, your teenage boy says, let's go for a walk outside. And you're like, what are you talking about? And it's all about Pokemon. I'm like, whatever it takes.
Who knew video games were causing people to be so physically active?
That's right.
Sure.
I guess since we're throwing out Pokemon, Paul, did you have a pick of the week?
I actually do this week. It's been a dry spell for movies that I've liked, and there's been a movie that I've been passing by that's been on demand. I mean, for months now, and it's called Thoroughbreds. And every time I see it, I think, well, that looks kind of interesting, and then I skip past it. So I finally dedicated a couple hours to watching it, and holy smokes, I like it. So it's this movie Thoroughbreds, as 2017. It's directed by Corey Finley. And it stars Olivia Cook and Anya Taylor-Joy and Anton Yelchin. Anya Taylor-Joy, you might remember from The Witch. She was also the female protagonist in Split. And I find her really compelling to watch in any case. But it's basically about two friends, one of whom is an absolute sociopath, but also the most likable character in the movie, and how they end up sort of plotting to kill the other friend's stepfather, and how they sort of interact with a drug dealer played by Anton Yelchin to help facilitate that. It's a really remarkable movie. I can't believe it's a debut feature because it's funny at times. The last scene where literally nothing happens as a static frame is one of the most suspenseful things I've ever seen. It's sort of touching and suspenseful and funny and really dark. So it just kind of checks all the boxes off for me. So if you haven't seen Thoroughbreds and you've enjoyed any of my movie recommendations, I'll throw that one out there.
The 0.01% of our audience who is watching.
There's that one guy in Poughkeepsie who was my recommendations.
I did see the trailer for that, Paul. It looked really good. That's the kind of thing that my wife would never, ever in a million years watch with me. I can only get her to watch romantic comedies, so Sophie, Fever Pitch, she would definitely watch that.
There you
with
go.
me.
I'm telling you, an excellent film.
Justin, did you have a pick before we get into the main topic?
Sure, yeah, I'll do a quick one. There's a book I read not that long ago called Indefensible by David Feige. He's a public defense attorney in like the Bronx, I think. It's a really great story it's a very noble work that he does. I think there's a lot of overlap between public defense and I think urban health primary care. Ever since like I read To Kill a Mockingbird, I think that's been public defender's voice is kind of a soft spot in my heart. Anyway, it's a very inspirational book. It's great. It's non-medicine, but related enough that it's worth a read.
Thank you. And I think now it's time for you to give us a, do we have a case tonight?
Nothing from you?
I wasn't good. No, I don't think so.
No soccer ball? No.
Has
Favorite
everybody
plunger
got
from Amazon?
does everyone have a TRX system for their, for their office yet? Before we get on to the show, we do have a sponsor for tonight's episode. This is ACP's Internal Medicine Meeting 2019. As I mentioned, this is in Philadelphia, Pennsylvania at the Pennsylvania Convention Center. The pre-course is from April 9th to 10th, and the full course is from April 11th to 13th, 2019. This is going to be an exceptional educational experience with world-class faculty from all over the country. There's over 170 scientific and practice-related sessions. I can tell you I attended last year. The clinical content was wonderful. I got to meet tons of people who I had only met before on Twitter or through social media. It was so much fun to meet people in person, get together with colleagues. Actually, some of my Curbsiders co-hosts I had never met before in person and got to meet them at the meeting. We will be there this year. I'm so excited to get back together with everybody and to do some learning and really dig into this meeting. It's going to be wonderful. Of course, you can earn CME to fulfill your state requirements. So join thousands. Hopefully this meeting will be bigger than last year. I think last year there was around 11,000 people attending, and I think we can beat that in Philadelphia. It is going to be a great meeting. So please register for ACP's Internal Medicine Meeting 2019 today. And remember that ACP members get the lowest rates when they register before January 31st. Learn what the ACP meeting has in store for you at annualmeeting.acponline.org, and we really hope to see you there. Now, let's just get into the case here.
Sure. Great. So we'll start talking about a patient who just kind of comes to clinic. So, in fact, we'll say it's a 28-year-old male. You don't know that much about him, but you're told that he has sickle cell disease. And he's here to basically establish care with a new provider. He will say he moved from another state. Has no acute concerns, says it's been about a year since any type of complication or crisis. Doesn't really have daily pain. Is on a medicine called Hydroxyurea. Has had 10 transfusions in his life. And those are his basic things that he tells you. So kind of starting from square one, can you talk a little bit about what is sickle cell disease? Is it different than sickle cell disease, sickle cell anemia? How would you explain the disease process of sickle cell disease and what the complications are?
Right, so sickle cell disease is a disorder of the hemoglobin, a congenital disorder, where you have a single base substitution of a valine for a glutamine, and you end up with abnormal hemoglobin, and those hemoglobin molecules end up sticking together and forming polymers in red cells, which changes the shape of the red cells and shortens the red cell survival and causes hemolysis. And there are I like to think of the two consequences of the polymerization of the hemoglobin inside the red cell. One is that the red cell is stiff and can't get through the microvasculature. We also know that part of the story of the stiffness and the inability of getting through the microvasculature is a combination of an increased expression of adhesion molecules and a whole bunch of downward effects that cause a very sticky environment in the endothelial space and in the vascular space, and so the red cells get stuck, and that's what causes a crisis. And then the second consequence of this is the hemolysis. So we know that about 30% of the hemolysis that occurs in sickle cell disease occurs in the vascular space, and that causes a scavenging of nitric oxide because you have free hemoglobin in the vascular space, and that scavenging of nitric oxide leads to its own set of consequences, including vasoconstriction and increased adhesion molecule expression. And so there's sort of these combination of events that happen with this abnormal polymerization of hemoglobin within the red cells. And this question about sickle cell disease versus sickle cell anemia, this is really semantics. So when a sickle cell doc says sickle cell anemia, they're talking about people who are homozygous for SS disease or S beta 0 thalassemia. So these disorders where you don't make any other type of hemoglobin, you might make some F and some A, but no other major types of hemoglobin, versus people who have SC disease who make S and C, and people with S beta plus thal who make S and some normal hemoglobin A. So sickle cell disease encompasses all the types of sickle cell disease, but sickle cell anemia is really limited to the people we consider to have the most severe form of the disease.
And so just to kind of reiterate that, the patients that have sickle cell SS and sickle cell beta thal typically have the more common sickle cell anemia phenotype and complications, whereas those with sickle beta positive or sickle C, SC disease, have less severe phenotypes, correct?
That is the way we think about it, but remember, everybody's sort of on this bell curve. So we see people with SC disease who have very severe disease, and people with SS disease who have fairly mild disease.
So I confessed to you, Sophie, early on that I don't know much about sickle cell other than the reading I've done for this podcast, because until recently, there weren't a lot of patients with sickle cell disease at Kashlak. Can you just give us so the SS, SC, the beta thal, can you kind of give us the basics of what is the hemoglobin, what should we have, and how do the sickle cell patients differ based on their genotype?
Right. So we should all have hemoglobin A, and people with sickle trait make some sickle hemoglobin and some hemoglobin A. And it's really important to be able to recognize what that looks like on a hemoglobin electrophoresis or actually an HPLC to see that quantifies how much hemoglobin you make. So if you have sickle trait, you will make 40% S and 60% A. If you have SS, then the majority of your hemoglobin is going to be sickle, so somewhere 80-90% will be sickle, and then you'll have some F and some A2 mixed in there, but most of it is going to be sickle hemoglobin. If you have sickle beta 0 thal, that means on one gene you're making sickle hemoglobin, and because it's a beta null mutation, that means that other gene doesn't make anything, so you just have the hemoglobin from the one gene, so you make just sickle hemoglobin. If you have sickle beta plus thal, then you make sickle from one gene, and because it's a beta plus mutation, that means it works somewhat, and you make a varying amount of hemoglobin A. And it's really important to be able to recognize that someone who has sickle beta plus thal will have 40% A and 60% S. And you'd be surprised how many times people mess that up and tell people that they have trait, or that people who have trait have disease, and people get very confused. And finally, SC disease means you make about half S and half C because you have a C mutation in one gene and an S mutation in the other gene. And there are some other genotypes that manifest as sickle cell disease, but those are really the most common ones we see.
And this, sorry, just because I'm not a smart person, but this sounded like a really important point, is the difference, if you could just reiterate the difference between trait and the S beta plus. Am I even saying this right? The two that can sometimes be confused. If you could just sort of just recapitulate the difference between the two and what they look like phenotypically, that would be helpful.
Yes, I think that's really important. So someone with trait will not have manifestations of disease, and they will have on their hemoglobin electrophoresis on their when you do an HPLC, which is the test we use to quantify how much hemoglobin, they will have more hemoglobin A than hemoglobin S, but people with S beta plus thal will have more S than A, and they will have manifestations of sickle cell disease.
Gotcha. Thank you.
Okay, so hemoglobin A is good. Hemoglobin S hemoglobin S is bad. Is that basic enough?
Yeah, I didn't realize that's what you wanted, but yes, that's it.
No, that I was making fun of myself for my limited grasp on the topic. I don't look at a lot of hemoglobin electrophoresis. Like once in a while I send it, and then I would have to just like look up, Google search, like what am I looking at here? How do I now interpret that? So
yeah, no, you're not alone. Lots of people, right? It's a rare disease, right? There are 100,000 people in this country who have sickle cell disease. It's a rare disease, and so you are not alone. Lots of people see one or two people, but those one or two people still need high quality care.
Right.
Okay, so coming back to our patient who comes into the office, can you talk a little bit about what preventative maintenance does this patient need, or what does this patient need in kind of a long-term basis to make sure that we're reducing the complications of sickle cell disease and maximizing his health?
Yeah, it's an excellent question. So there are some guideline-based recommendations for routine health maintenance for people with sickle cell disease. One is they should get the routine health maintenance that they would get if they didn't have sickle cell disease. That's number one. But on top of that, we think a little bit differently about patient risk. So because people with sickle cell disease don't have a functional spleen, if they have a SS, they've autoinfarcted their spleen. Sometimes as a kid, people have their spleens removed. But you can just assume that an adult who walks into your office with sickle cell disease does not have a functional spleen. And that means they need to be immunized against encapsulated bacteria, so pneumococcal vaccinations, meningococcal vaccination, H-flu, and then the influenza vaccine too is also crucial for this patient population because we know they don't do well when they get the flu. And then routine health maintenance also includes some standard laboratory tests. So we do a CBC and a reticulocyte count and chemistries to look at kidney and liver function. But one of the really interesting things that we should talk about is that the serum creatinine is an incredibly poor measure of renal dysfunction in people with sickle cell disease. So the renal medulla is the most hypoxic part of the body, and so the kidney is one of the earliest affected organs in this disease. So kids can't concentrate their urine; they have hyposphenuria, and then as people age, and as children, they have hyperfiltration and they hypersecrete creatinine into their urine. So we expect their creatinines to be quite low. So it's a really poor measure of overall renal dysfunction. As when you start to see the creatinine rise, that means they've lost a significant amount of their renal function. And so the recommendation is to screen, looking either for proteinuria or microalbuminuria. There's still up in the air about which one's the best test on an annual basis. To see if there's evidence that they're spilling protein, which is an early sign of renal disease.
Go ahead.
In addition, we recommend every patient it's a sickle cell disease that can affect every organ in the body. Annual eye exams looking for signs of retinal disease, which increases the risk of vision loss, is also an additional recommendation for this patient population.
Not that you have a sense at our level, which is incredibly basic, it sounds like, and I won't speak for Justin, but do you mind just if we can get to the very beginning with this patient presents to the office for the first time, what sort of history is important to ask about their disease? So the preventive stuff's helpful, but I noticed, we talk about triggers and pain crises, but like, is there anything that is really historically important that we should be getting out at that initial visit for a first-time patient presenting with sickle cell disease?
Yeah. So when I meet a patient for the first time, I sort of the first and key thing I ask them after I find out at what age they were diagnosed, which now because there's newborn screening, most people are diagnosed at birth. I ask them what a typical crisis is like. I think it's really important for me to understand and for them to get a feel for, one, I know what I'm talking about, but also that we get a sense of what a typical crisis is like. Because when a patient presents as an atypical crisis, that's a warning sign that something bad might be going on that you really have to think about. So I talk to them about what a typical crisis is like for them, where they have pain. I also ask them what works for them when they're having pain, whether they're treating themselves at home or when they're coming into the emergency room. Because that's useful when they come into the emergency room or into our infusion clinic, so I know what to treat them with. So those are the first key things I talk to them about. I talk to them about whether or not they have chronic everyday pain, because that also changes our management and changes how we think about things. And then to talk to them about what complications they've had. So I run through the most common ones, whether they've had leg ulcers, whether they know they have proteinuria, whether they've had a stroke, whether they've had acute chest syndrome, whether they've had blood clots. All of those things are really important in thinking about how to manage them in the future. Another crucial thing we talk about is their transfusion history. So I want to know how many units of blood they've had in the past, because getting over 20, 30, 40, 50 units of blood suggests that they might be at risk for iron overload. And then I ask them whether or not anyone's ever had trouble finding blood for them, or if they know they have any antibodies, because patients who get transfused are at risk for developing antibodies to other people's blood. And it's really important to know that, because you may not pick it up on a type-in screen that day.
That was a great question, Paul. I'm glad you thought to ask that. So this gentleman, if he's coming in telling you he has hemoglobin SS, do you take that as face value? Or a new patient coming into any system, would you retest them with a hemoglobin electrophoresis and the HPLC?
Yeah, so if I don't have the test, I will repeat it, because often patients don't know exactly what they have, and it's useful for me to make sure that I've confirmed the correct diagnosis.
That just seems to be something that I've seen in practice where people documented in the chart what is the patient's genotype, and patients may or may not understand that themselves, and they might kind of tell you they have SS, but maybe they really have something less severe, or they just have trait, which I've also seen. So.
Right, and I feel like there's a rich oral history of trait, especially, that just gets carried on in perpetuity without any kind of testing or confirmation. Like, we just take it on face value. Yes,
met a woman a few weeks ago who said, my brother had sickle cell disease. I have trait. She didn't have trait. She had disease. And just no one had ever bothered sending the test, and she did. She had disease. And you don't see that as much anymore, because starting really in the 1980s, newborn screening started. But when you're meeting a 40, 50, or 60-year-old person, it is highly possible that they have never been tested.
Oh my gosh, I'm having palpitations.
I did want to ask, what is the life expectancy like now? And let's say this 28-year-old man, let's say he hasn't had much contact with healthcare, but now he's starting a family, and he wants to know, am I going to be there? Am I going to live till 90 years old? What would you tell this young man?
Yeah, so that's a really good question. In the 1970s, the average life expectancy was 17. We now know that about somewhere upward 95% of children born now will live to their 18th birthday, which is great, and there's been great strides in improving overall survival there. The adult population, it's a little bit more fuzzy. We don't know exactly what the life expectancy is. There's a little bit of data out of the UK and the US suggesting now that the average life expectancy is into the 50s or 60s. I have a cohort of patients who are in their 70s, but it's hard to say. Someone who's 28 now. If you look back, when you talk to my patients who are 50 years old, they'll tell you, oh, my parents were told I wouldn't live to 10. I was told I wouldn't live to 20. I was told I wouldn't live to 30. And here they are at 50, and me telling them, right, what they should do, because they may not live till really doesn't carry a lot of weight for them. But things have changed now. They're not telling kids that anymore. And we really are trying to strive for, improved overall survival and hopefully a near normal life expectancy, but we're not there yet. We still think the overall life expectancy is decreased by 25 to 30 years compared to the general African American population.
So for this patient, what are, other than the health maintenance and getting a good history of the complications, what are some interventions that are evidence-based that can help reduce these complications and can help medically optimize these patients?
Yeah, so he's on the number one intervention that we have for this disease, which is hydroxyurea. And hydroxyurea is a great drug. It works in multiple ways for people with sickle cell disease. It was originally thought that it would be helpful because they knew years ago that it increased fetal hemoglobin. So when we were all fetuses, we all made fetal hemoglobin, and then most of us, about 1 year of life, completely stop making fetal hemoglobin and only make hemoglobin A if we don't have sickle cell disease, or hemoglobin S if we do. But you can reverse that change by giving people hydroxyurea. And so hydroxyurea does increase fetal hemoglobin levels, but it also lowers white counts, it lowers adhesion molecule expression. It's an NO donor. It's a great drug. And we know it decreases crisis frequency, it decreases the risk of acute chest, it decreases the need for transfusion, and 2 observational trials have shown improved overall survival for people on hydroxyurea. It's a great drug.
And you mentioned just maybe some white blood cell suppression. Is there anything that the primary care doctor should be mindful of as they're for a patient who's on chronic hydroxyurea?
Yeah, so I think primary care doctors can prescribe hydroxyurea. It is, people think of it as chemotherapy, but that's just because it was what it was used for first. But it's a great sickle cell drug, and it does cause myelosuppression. So you do have to monitor counts. But that's also how we decide how to adjust the dose. So when we treat somebody with hydroxyurea, we treat to maximally tolerated dose, which means pushing the ANC down, the absolute neutrophil count down to between 2,000 and 4,000, really closer to the 2,000 than the 4,000, while maintaining a platelet count of greater than 90,000 and an absolute retic count of greater than 90,000. So it's a really easy drug to use. You just have to monitor counts initially on a monthly basis.
I've seen a lot of the patients that come into the hospital are either on hydroxyurea or tend to be getting chronic red blood cell transfusions. Can you talk a little bit about what patients wouldn't be on hydroxyurea or what the alternatives are for hydroxyurea?
So the best evidence base for the use of chronic transfusion therapy is in primary stroke prevention in children who've had abnormal transcranial Dopplers. Although there's data to support that as those kids age, they might potentially be able to be switched over to hydroxyurea, or secondary prevention of stroke, although the data is not great, but everyone believes that if you've had a stroke, you should be on chronic transfusion therapy. And we know that chronic transfusion therapy, when the standard protocols are to decrease the percent of hemoglobin S to less than 30%. And we know when we do that from these studies in children that we decrease crisis frequency, risk of acute chest syndrome. I have patients who've been on chronic transfusion therapy since they were 2 years old. They're now in their 30s and 40s, and they don't know what a crisis is. So it's a very effective therapy, but obviously it requires a lot of involvement in the healthcare system, exposure to blood products, and so it's not often patients' first choice when it comes to therapy. Hydroxyurea is indicated most clearly in the data that is there to support its use in people with sickle cell anemia and not necessarily in people who have the variant genotypes. So patients with variant genotypes who have frequent crises, we don't have great therapies to offer, and so that's often the time in which I'll use chronic transfusion therapy, or in patients who have failed hydroxyurea therapy.
So it sounds like if they've had history of stroke, if they have failed hydroxyurea therapy, or if there's another variant, if a patient came in on chronic red blood cell transfusions, most likely it's one of those 3 things that have occurred.
Correct.
I have to say, practicing adult medicine, I was not really aware of this practice until I was reviewing for this interview. I haven't seen it done a lot. I guess the logistics of it just seem like it would be very challenging if someone's getting transfused every couple weeks and you're monitoring their hemoglobin S levels. It seems the logistics would be really challenging there. And can you just also speak a little bit about I know it's not as much the transcranial Doppler and what they actually see on that?
So it's flow rates when they do the transcranial Doppler. So very fast flow rates suggest an increased risk of stroke. And so the STOP trials, there were STOP 1 and STOP 2 trials in children, demonstrated that if you use this as a screening test and people with high values, you put them on chronic transfusion therapy, you could really decrease significantly their risk of having a stroke. Subsequent trials have shown that as long as you haven't had a stroke, if you can potentially switch those kids to hydroxyurea at some point, potentially at least 18 months after they've been on chronic transfusion therapy. But it's a useful screening test in children. Adult skulls are too thick, and so we can't use transcranial Dopplers. And so we can't predict who's going to have a stroke or not, unfortunately.
And I think if you don't mind, and we don't have to spend a whole ton of time on this, but would you mind just sort of touching on the potential complications of folks who are on chronic blood transfusions?
Sure. So there are two ways we do chronic blood transfusions. One is simple transfusions, which means we just give someone 2 units of blood once a month to decrease their percent S and bring up their hemoglobin some. The risks associated with that are exposure to blood products, so there's some infectious risks, but those are pretty small. You can develop antibodies to other people's red cells, so people should get red cells that are phenotypically matched. And then the most common side effect we see that's the most concerning is iron overload, which can happen with simple transfusions, right? Because the only way you really can get rid of blood is by bleeding, and so you're just adding iron on. And so when people have problems with iron overload, that's often a time when we'll switch them to exchange transfusions, which is another way of doing transfusions, where you hook someone to a machine, you remove their blood, you put in blood that has normal hemoglobin in it. That often requires a large access device, so it is a little bit more invasive of a procedure. But if done in sort of the best environment where patients are coming in with a hemoglobin of 10 and leaving with a hemoglobin of 10, it actually is a bit of a net negative iron load, and you can actually make people iron deficient on chronic exchange transfusions.
Oh, interesting.
Yeah, so we will sometimes, in people who are on simples and are iron overloaded, we will switch them over to exchanges. And people with variant hemoglobins, the SC folks who need to be on chronic exchanges because they have frequent crises and we don't have a lot of other therapies to offer, they typically have hemoglobins of 10 or 11 to begin with, and so we need to do exchanges because we can't do simple transfusions in them. If you transfuse a patient with sickle cell disease to a hemoglobin that's too high, you can increase viscosity and cause strokes or crisis or other complications. So typically we don't like having hemoglobins greater than 10 in people with SS disease, and really not too much above the baseline for people with variant disease.
Do you track the ferritin there? And if so, how often? What can we be looking out for as generalists?
Yeah, so we do check ferritins monthly, but you got to be mindful that unlike beta thal patients who get transfused because they don't make blood, people who have beta thal major, where ferritin is a better test for iron overload than it is in sickle cell disease, because ferritin is an acute phase reactant. It doesn't necessarily correlate very well. We do follow it monthly. We don't get really excited when it leaps up, but we follow trends. Annually, we will do MRIs. There are special kinds of MRIs that you can do that can give you the iron quantification, how much iron is in the liver and how much is in the heart. And so we will do that on an annual or semi-annual basis to assess iron overload.
I have never heard of that before. That is okay. Learning a lot here. I did, and something else that I saw that I was just really alarmed at is the New England Journal had this review in 2017, and they just had these just the body and every system and just kind of labeling how all the systems are affected. And one of them was cognitive impairment and the silent cerebral infarctions. Clinically, is that a huge problem for these people in their 20s, 30s, 40s? Do you see that a lot clinically?
We do, and it is a huge problem. We know 30% of kids will have silent cerebral infarcts, and there's just not a lot of data in adult populations. But to assume that people don't live with the damage done in childhood for their whole lives is unrealistic. But there's some recent data by Mike DeBon suggesting that adults go on and also have silent cerebral infarcts, and that if you've had a silent cerebral infarct, it increases your risk of having another silent cerebral infarct. And so I do think this is really important. And people often say this is a frustrating population to take care of, and they're dealing with chronic pain is problematic. But another aspect of this is this neurocognitive dysfunction. You tell a patient to do something and they're not doing anything you want them to do, and you don't quite get why. Those are the people who need to be tested for neurocognitive dysfunction. It's pretty common.
I just never thought of that because it's definitely where I practice. These patients are on opioids. A lot of the times these patients are very forthcoming. They're smoking marijuana. Is that affecting their cognition as well? Paul, we've talked about this on prior shows. I know we have a...
And the answer is, who knows?
The answer is who knows. But I never really thought that this is... these patients have this just very premature, could have this premature cognitive impairment based on the insults to their vasculature. It just hadn't occurred to me.
Yeah, I think we need to be more mindful about this and really think about it. So, right, those patients who you're just incredibly frustrated with for lots of different reasons probably have a lot of cognitive dysfunction. And it's a lot of executive function. So if you're just trying to have a regular conversation, you might not pick up on it at all. But if you delve just a little bit deeper, you will discover that there are a lot of issues.
Interesting. And so if you have access or ready access to neuropsychological testing, that's something you have a fairly low threshold to refer patients for?
Yes.
Yeah, I just like it seems like it might even be something that could improve the physician-patient relationship if you're just like you could have more insight into the behaviors you're seeing, or you could meet them where they're at more than you would if you were ignoring the fact that existed.
Yeah, absolutely. I think that it is really important, and it really helps the physician or the provider understand where the patient's coming from.
So we're sort of moving towards this. We have a couple cases of acute complications of sickle cell, but with this young man, we just mentioned opioids. That's a huge issue in this population. Can you tell us what are your thoughts on how does the sickle cell population tie into the opioid crisis, and do they get opioid use disorder?
So I think they do get opioid use disorder, although some others of my colleagues would argue with me. I think there's some key things to keep in mind. If you're sitting in an emergency room somewhere and a patient rolls through the door, it is not your job to figure out whether this is a crisis or chronic pain or real pain. It's really, right, none of us, I work with a great psychiatrist who's really works with our sickle population, and he's like, it just, right, believing or not believing, this is not part of the story here. It's the question is, what's the most appropriate thing to do at this moment? And I think ED providers are in a tough spot. They want to do the right thing, and they're torn by the dangers of opioids and the benefits of opioids. And so what I typically tell our frontline docs in the ED is that really it's not up to them it shouldn't be up to them to decide who needs what. And that's a reason that every patient needs a hematologist, because every patient should have a patient-specific treatment plan when they're rolling through the emergency room. And a patient who doesn't have one, you really can't be the one guessing whether this is a real crisis or not, because there is no objective measure of crisis. There just isn't one. And that is part of the struggle here. And so if you're on the front lines, you got to treat and treat appropriately.
You would extend that to when Paul, Justin, and I are working in the hospital. It's not really our job to sort that out.
Right. It's really not. I mean, we don't spend time sorting out whether we believe the patient or not. It has nothing to do with it. It's wasted time and effort because you're never going to figure it out. And pain, right? Pain is a real challenge. And the question is what's the best way to manage that pain, right? If a patient is depressed, they're going to have pain because they're depressed, and that aspect of their disease has to be managed as well. And so it's complex. And so we have to treat the sickle cell disease and its manifestations, and that means using hydroxyurea or chronic transfusion therapy. And we also have to address the behavioral side of things as well. 10 years ago, a kid like this came rolling through the clinic complaining of chronic pain. I would probably have put them on an opioid. I now, honestly, I think a little bit harder about those decisions, because after doing this for as long as I've been doing this and seeing the data that's coming out, there's no data that chronic opioid use improves quality of life, and there are real questions about its harms. And so we try to be a lot more thoughtful about how we're using opioids. In the acute setting, it's what patients need and should have. In the chronic setting, they need doctors who think about, or providers who think about, what the appropriate way to manage pain is for that individual.
What can you give us an example of what might be a typical pain regimen for someone like this gentleman who's not getting admitted to the hospital on a frequent basis? Maybe he gets admitted once a year. What might a typical pain regimen look like? So
I actually firmly believe that patients with sickle cell disease, just like this guy who doesn't come in very often, should have short-acting opioids at home so that he can manage his pain at home if he needs to. And he should use a stepwise approach. right? He knows at this point when the crisis comes on, if it's going to be a really bad one, if he can get away with some non-steroidals, assuming his renal function's okay, whether he can get away with non-steroidals or whether he needs to start using some opioids. And I like to start with oxycodone. I don't like Tylenol mixed in because I worry about too much Tylenol and acetaminophen. But I think it's perfectly reasonable for someone like him to have oxycodone on the shelf so that he can try and manage his pain at home instead of having to come in for acute care.
Do you ever use extended release opioids in this population, or just try to stick to the short acting?
We have a boatload of people who are on extended release opioids because we have had a long history of using them.
Sure.
We're moving away from them, but in the appropriate patient, it's still the appropriate medicine. And it's hard to describe what exactly the appropriate patient is. But an older patient who has avascular necrosis, who doesn't have surgical options, then it might be the most appropriate management tool. But we really work together with pain management to make those decisions. And pain management that has an awareness of sickle cell disease and its complications.
Mm-hmm.
Sophie, you mentioned, just to go back, that there was no objective measure for an acute pain crisis. Is that correct? So LDH levels or no other lab finding can really help support evidence if a patient does come into the ED complaining of pain. Is that correct?
That is correct. Their labs can look just like they did the week before when they were in clinic. You can see a drop in hemoglobin and an increase in Retic, but you certainly don't need to have that in order to have a crisis. The gold standard that you're having a crisis, that a patient's having a crisis, is that they tell you they're having a crisis.
Yeah. So since, as we do with our pretend patients, we torture them. So we're talking about acute pain. Let's actually give some specificity to it. So let's say this patient, it's summertime, the patient's out swimming and having a good time, and just suddenly starts experiencing extreme pain in his left upper shoulder. And so for this specific example, the patient comes in, they're reporting pain in the setting of sickle cell disease. So from a musculoskeletal standpoint, it sounds like lab work is not terribly helpful. Is there any other workup that might be needed, and how do you triage the severity of this pain complaint?
Yeah, so I am checking laboratories. First of all, we're going to do a little bit of education when he's feeling a little bit better about jumping into the cold water on a summer day. If he hasn't already learned his lesson, most of my patients can't go swimming because they get a crisis when they do that.
Jeez,
Yeah.
That never would have occurred to me. Holy cow.
Yeah. Or, sitting in a cold movie theater, all these sorts of things, right, that these patients just can't do. So the first question to ask is whether this is a typical crisis. If this is not typical crisis, then the hair's standing up on the back of my neck, and I'm like, oh, what badness is coming my way? If this is a typical crisis for this patient, I do check a CBC. You don't want to miss things like an aplastic crisis or something else going on. You want to make sure this patient's making blood because they have a chronic hemolysis. We need to make sure they're making blood, so we'll do a CBC and a Retic. If the patient says, yeah, this is my typical crisis and everything else looks okay, I mean, we still in our infusion clinic will check chemistries. You could argue whether they're necessary or not, but I would do that sort of routine standard workup. If the patient says it's typical crisis, then I would treat with their typical regimen because we know what works for our patients, right? Because we've spoken to the patient about what that is, or we've done it in the past, and so we'll treat the patient for pain with some IV fluids and some pain medications and see if we can't get things to turn around so they don't need to be admitted.
And I feel like a fool for asking, but I'm just going to go ahead and fire away anyway. How helpful is the physical exam in these particular instances? What things are you looking for? Is it, does it change your management at all? And what kind of things we should be mindful of when actually examining a patient with an acute pain crisis?
Yeah, so certainly the vitals, making sure they're not febrile and tachycardic, although often they're tachycardic because they're in pain, but certainly something to be mindful about. Their respiratory status, their pulse ox is also key. You want to make sure they're not hypoxic. And then, physical exam, you're listening to the lungs, listening for any changes, although typically people with acute chest often don't have any lung findings. I try not to torture the patients by doing a detailed exam of the place that hurts like the Dickens, because that often doesn't help. But you want to visualize it. You want to make sure there's no swelling over the area and that you're not missing something else. One of the key things to remember is that just because you have sickle cell disease does not mean that everything that ever happens to you in your whole life is just sickle cell disease, right? You can get septic arthritis, you can have lots of other things. And so you do have to keep your differential diagnosis wide until you've really settled that you know what's going on with these patients.
My colleagues would kill me if I don't ask this question. PCA versus like demand opioids, IV versus oral. Does it matter? Should we even think about that? I've worked in places where that's kind of a fight between the patients and the providers, and I just wondered how do you approach it?
So no orals, because he has orals at home. If those had worked, he wouldn't be there in front of you. So we move right to parenteral opioids. We have an infusion clinic, so up front we're going to bolus. Everyone should get bolused initially because even with a PCA, it takes a while. And there's not great data, but there's a little bit of data that suggests, for at least for hospitalized patients, that PCAs are better than bolus therapy. And when you think about the half-life of IV dilaudid, giving bolus really doesn't make sense. The PCA makes a lot more sense when you're using these short-acting opioids versus using bolus therapy. So our preference and actually our policy is that patients who are admitted to the hospital go on a PCA. And you know, you can start a PCA in the morning and then leave your patient and round on them again the next morning, and that is not the effective use of a PCA, right? You want to come back a few hours later and make sure it's working. And lots of patients complain about PCAs when they get ignored once they're on them. And so you need to do the every 3 or 4 hours assessment, make sure it's working, make adjustments. I think the real key when a patient gets admitted for a vaso-occlusive crisis is maximizing that pain management within the first 24 hours. Because if you can really get things to settle down, my typical approach is aggressive the first 24 hours. They're feeling better. I then don't make any changes for 24 to 48 hours, and then I start to talk to them about weaning down.
With the PCA, do you have like a formula that you like how you adjust? You go up by 20% or down by, like, is there any science to that, or is it all just sort of getting a feel for it?
Most of it's getting a feel for it, but the key, the one and the most important things you have to do if you're putting your patient on a PCA is you must calculate the 24-hour dose that they received. So you put someone on 0.3 of hydromorphone every 10 minutes, you think, well, that's a pretty tiny dose. And then, they're on a tiny dose, but you never bother to calculate it, and you discovered that they've gotten 50 milligrams of IV dilaudid over the last 24 hours, right? It's a whopping dose of dilaudid. And so you just want to you have to check the 24 hours. That's how you know how you're doing. And when you begin to wean, right, patients can push the button more. So you think you've weaned, but you really haven't because they've just pushed the button more. And so you really want to keep track of that. We do find that in patients who don't come in very often, they often need large doses of IV opioids. There's no science around any of this, but sort of lots of my colleagues will note that they need really high doses. And they're actually usually pretty with it. But once you get over those first 24 to 48 hours, then they quickly wean themselves down. So it's interesting. I'm worried a little less in people who don't come in very often about the amount of opioid, especially in a PCA, which is much safer than just throwing bolus doses on people. And unlike patients who maybe are in the hospital a little bit more and maybe stay a little longer, who aren't getting 50 milligrams or more of dilaudid every day, right? At some point you have to say it's been 3 or 4 days of 50 milligrams of dilaudid. If this isn't working, it's not going to work. And those people we think of as having failed opioid therapy. Start thinking about other therapies that might be helpful, like ketamine or meds like that.
These patients all get a basal dose and then the demand dosing from the PCA?
And we rarely use the continuous. You often just give a bolus dose. Okay. So, but you have to think about the patient who's in front of you. So
sure.
often patients haven't slept because they've waited at home and been miserable for a few days before they come in and they're exhausted. And you really, right, they have to get sleep to get better. The minute they fall asleep, if they're only getting bolus dosing, they stop getting bolus dosing because they've slept through their ability to push the button. And so sometimes we will use low dose continuous. It really depends on the patient and the situation, sometimes just at night to get them through so they can get some rest. And then wean that off first. Most of the time, we can get away with just using bolus dosing.
Okay, interesting. Thank you.
If a patient's on long-acting opioids at home, though, we do continue those.
Yeah. Okay, I see. So you continue those, and the bolus PCA is on top of that.
Right.
Very good. One of the other questions that Justin we had talked about before, the retic count. Reticulocyte count. How do you interpret that, and what's the utility of continuously checking it during admissions?
So the retic count tells you how many new red cells you're making, right? And you want to use that absolute retic count, right? So a retic percent of 1% is considered normal, but it's only normal if your hemoglobin is normal, right? It's not normal if your hemoglobin's 5. So you can use an absolute retic, and your absolute retic really should be greater than 90 or 100,000 if you've got sickle cell disease and you have a chronic hemolytic problem. It is a useful tool, right? If having no retic response at all, so retics of less than 1%, suggest an aplastic crisis. So you do that at admission. I don't know that you need to check a retic every day, but sometimes when we're running into trouble, and the hemoglobin has fallen, and the first question I have is, what's the retic? And they're like, well, we didn't order one today. So it's a pretty cheap test overall.
Okay, so you like them. You like
I do. I'm a fan. I am. It's cheap. It's easy.
That's why we wanted to talk to you. We want your opinion. We want to know what you do. It's certainly more informed than what I've been doing.
While we're still on this, maybe I had a patient I remember very vividly that I admitted who was in a typical crisis, and in getting the opioid therapy that helped his pain, he suddenly just had very severe itching. That soon became more of his complaint than the actual pain. And it was pretty difficult to watch. And we tried PO Benadryl, IV Benadryl. I guess, is this something that you commonly see as a reaction to high-dose opioids? And what are ways to potentially treat the itching complication of the opioid treatment?
Yeah, so it's a common side effect of all of these opioids, right? Patients will tell you they're allergic to morphine, but really it just causes itching, and it's a side effect, and it can be really miserable to watch someone who just is constantly scratching. So other than those therapies, we try to avoid IV Benadryl and use oral Benadryl, diphenhydramine, and Atarax and those sorts of agents. When those don't work, actually, it's been studied in pediatrics. I don't think in any adult study with sickle cell disease, but putting some Narcan in the PCA actually can really help decrease the itching and some of the other side effects of the opioids. And so I think for the kids in our hospital, at least, it's pretty standard practice that their PCA includes a little bit of Narcan, and it really helps control the itching.
Like mixed in?
That's crazy.
Mixed in. Yeah,
I'm incredibly dumb for not understanding how that works.
I know.
They press the button and they're getting naloxone along with their hydromorphone.
Yeah. That is the way it works. So it's a pediatric anesthesiologist at Hopkins who came up with this concoction, and it really works. We actually had to use it last week on a patient who was just complaining of terrible itching. We don't use it very often in the adult population, but I know it's pretty common in pediatrics. It's the side effects. I'm sorry.
That's pretty cool. All right, that'll just remain as an unknown.
Yeah.
I think
people are going to listen to this episode and talk about that on rounds, though. That'll be
okay. I think
I'm not going to be able to sleep tonight.
I think we need to. I think we need to get into a bit about acute chest at the end here. I was going to ask about the transfusion threshold too. We're kind of going back and forth between the pain complications and the hemoglobin here, but I had just asked you about the retic count. What about the transfusion threshold? Because in the articles I was reading, they're talking about keeping the hemoglobin greater than 10, certainly at least perioperatively. I routinely see patients drift down to the low 6s, even high 5s before someone transfuses them with an acute crisis, unless they're having like a severe complication like acute chest or something. How should we approach that?
Yeah, so it's a great question. It is part of the American Society of Hematology's Choosing Wisely campaign that we do not transfuse people just because they're having a crisis. If you're going to transfuse someone, it should be because they're having a symptomatic anemia. So people always ask me, what's my threshold? I don't really have a threshold. Hemoglobins below 4 make me really anxious. It's really about symptoms and reticking. So if you're more anemic than usual and you are not reticking, you need to be transfused, right? Because people have ongoing hemolysis and they're not making new blood. This is a bad combination, and so they need to be transfused. Patients who are hypoxic, really people with symptomatic anemia, then that means that their anemia needs to be treated. The perioperative period is a little bit different. We know there's some good studies looking at perioperative transfusions. And the general guideline is that if you have sickle cell anemia, you need to have a hemoglobin of 10, which can be done with simple transfusions, or you can be exchange transfused. But really the goal before surgery is a hemoglobin of 10 for people with sickle cell anemia.
I think that's certainly much more clear than it was, and it's more in line with what I'm seeing. And I'm not seeing a lot of these patients before they go for surgery, so that's probably why I'm seeing the lower hemoglobins in general.
So our friend who's in the clinic goes home and is doing well, but then gives you a call about a week later saying that he feels ill. He took his temperature and it was 102.2. So we were hoping you could give us a little bit of insights into what a fever in a patient with sickle cell disease implies and how to manage that.
Yeah, so unlike me, if I got a fever of 102, I'd take some, ibuprofen and drink lots of fluids and stay home. In his case, he needs to come in and be evaluated because he doesn't have a functional spleen. He's at risk for having severe life-threatening infections, and someone needs to lay eyes on him. Probably 102, he's going to buy himself a little hospital stay potentially, but right, he needs to be evaluated. Flu can be very dangerous in this patient population. Obviously, other infectious problems, the development of acute chest syndrome, he has to be evaluated.
Does that evaluation, would that include blood cultures and empiric antibiotics typically?
So I would not put him on necessarily empiric antibiotics, but I would do the full workup, the labs, check his white count, do blood cultures. If he looks toxic, then I'm going to cover him empirically. But if he sort of looks stable, then I would watch him if I don't have an identifiable source.
With the rest of our time here, I would like to talk about acute chest syndrome. We kind of already did the part 1 with the fever there. So I guess we can, maybe Justin, you could just kind of take it from there, and let's say we get our basic workup on this guy, and then you can bring us into the case.
Sure. So our gentleman is hospitalized for treatment of an acute pain crisis. On the 3rd day in the hospital, he starts to complain of severe chest pain and shortness of breath. His oxygen saturation drops to 92% and is placed on 2 liters of oxygen by nasal cannula. So based on this case, can you talk a little bit about what is acute chest syndrome, why it's worrisome, and then how do we diagnose acute chest syndrome?
Sure. And so the case you present is actually pretty typical. Patients don't usually present to the emergency room with acute chest syndrome. They can, but they don't usually. They occlusive present with a typical vaso-occlusive crisis or a vaso-occlusive crisis with much worse pain than usual. And then within a couple of days, we'll develop acute chest syndrome. And an acute chest syndrome is just that, a syndrome. It's a clinical diagnosis, and it requires a new infiltrate on chest X-ray, a fever, and respiratory symptoms, so cough or wheezing and chest pain. So really just a clinical diagnosis. The radiologist can't tell you that the patient has acute chest syndrome. They can tell you that there's an infiltrate, and then you have to put the rest of the pieces together. They're having a fever and chest pain, and that defines acute chest syndrome. So you can have mild acute chest syndrome, and you can have really bad acute chest syndrome. And we think there's probably this real spectrum of what this disease means. So if you have a community-acquired pneumonia and you come in and you've got, an infiltrate and fever and chest pain because you have a pneumonia of some sort, that's probably one kind of acute chest syndrome. But the one that you sort of described here, where the patient came in with a vaso-occlusive crisis and then 48 hours later is having severe chest pain, that might not be infectious. In fact, that could be fat embolization syndrome. So that someone has a crisis and then fat gets released from the marrow and travels to different parts of the body. And the more parts of the body it goes to, the sicker the patient is. So there's this spectrum probably from acute chest syndrome, where the fat just goes to the lung, versus it going to the brain, the kidneys, the liver, and you having multi-system organ failure. And those are the people who we really worry about, are the people who have this acute form of acute chest syndrome. Their platelets might drop. They're really hypoxic. Those are the folks who can go downhill very quickly, for which they need some intervention. And the intervention is transfusion therapy, because the problem with acute chest is that you're having areas of the lung that aren't getting oxygenated, which means the blood that's going through there is not getting oxygenated, and then that blood sickles. And so you have this cycle of event. And if you don't break the cycle by putting blood in there that won't sickle, the patient does very poorly.
When you're saying there's the spectrum, I feel like I have seen the patient who overall looks relatively well. They have chest pain. They have maybe a low-grade temperature, and then like kind of maybe an infiltrate on chest x-ray. Those patients, I would feel silly kind of sending them for an exchange transfusion. I tend to just, what I tend to see done, and what I've done for some of these patients that don't look sick, where I don't like feel scared that this patient's going downhill, is just sort of just the normal stuff: oxygen, fluids, pain control. I may give antibiotics if I think it's appropriate. Is that sort of in line with your practice, or do you treat all these patients more aggressively if they technically meet criteria?
No, I think that's just the way you should be doing it, right? Is that in the prospective study that looked at over 600 cases of acute chest syndrome, only 72% of the patients required transfusion therapy. So not everybody with acute chest syndrome requires transfusion. It's really about, again, that symptomatic anemia. If they're hypoxic, then they probably need some blood. And this requires a little bit of nuance about whether it's a simple transfusion or an exchange transfusion that you do. And that's probably maybe a little bit more complicated than we need to be doing here. But being able to recognize when you need to call for that kind of help, whether it be simple or exchange, is the important piece. So someone who's got a little bit of an infiltrate, a little bit of a fever, but satting 98% on 2 liters, and they've got a hemoglobin that's reasonable and a retic that's reasonable, I'm not giving blood to. But somebody who's tacking at 120 on 4 liters of oxygen, satting at 92%, is going to get blood.
That's clear. Well, I think we really, I know we could ask you about a ton of other complications, but I think we probably got to start wrapping up. So maybe Paul, or if you have any like last minute questions that you wanted, burning questions.
Well, something we talked about a little bit, and it sounds like this might be a whole episode for a different day, is the transition between sort of pediatric and adult care and what that handoff should look like ideally. And I don't know that, I'm not sure we have the time to really deeply get into it, but we were talking sort of off the air about how every so often a patient will just show up with a diagnosis in hand and no real sort of transition plan, and I kind of lose my mind and basically try to just get them to see a hematologist toot sweet, because I feel like that's my big contribution. But rather than that mess, what does a good transition look like, and how should we manage that?
So a good transition starts at the age of 12 or 13, where kids are learning about their disease and how to navigate the medical system. And then they transition at 18, 19, 20, whenever the age of transition is for wherever you are. And what should happen is that there's a summary from the pediatric provider and an identified adult provider. Often the transition to primary care, it's often useful if that happens first, and then they switch to a different hematologist. But there should be a formal system. There's the GOT transitions program. So there, and the American Society of Hematology has a transition tool that all the pediatricians should be using to prepare kids for transition to adult care.
Justin, any final
Yeah, I have one question because I think, if I remember right, the evidence is pretty impressive. For any patient that's admitted to the hospital that has sickle cell disease, is there a way to prevent acute chest syndrome? And more explicitly, incentive spirometry, if I remember right, is actually a really big helpful tool. Is that right?
Yes, when you say there's a lot of data, you mean there's a lot of data in pediatrics, just where the data is. But it is, and it's good data, and it suggests that it's especially when you're putting at least kids on morphine, if you give them incentive spirometer, you really can help prevent acute chest. So everyone should get an incentive spirometer.
That's simple enough. I think I can follow that one. Sophie, can you give a couple favorite take-home points for the audience?
Yeah, every person with sickle cell disease should have a hematologist, and it's really about not making assumptions about these patients when they roll through the door. I really love my clinic. You get a very distorted view when you're the inpatient provider or the resident about what it's like to have sickle cell disease and what these patients' lives are like. But you come to my outpatient clinic and you see people who are living their lives, who barely graduated college because every time finals rolled around, the stress caused them to have a crisis. When a week before their wedding, they had a crisis. After the wedding, no honeymoon because they had a crisis, and they've lived their life like that, and yet they're still able to function and take care of their families and go to work every day. And so they're an incredible group of people, and I'm really lucky to have the opportunity to take care of them. And so I think every resident should spend time in the outpatient sickle cell clinic to see what it's really like to take care of this patient population.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
There, thank you.
I was asleep.
It's past your bedtime. Get the show notes for this show at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
I thought you were having a stroke, Paul. I was like, what is... Nope, it was my fault.
It away.
It was just my fault.
We are committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes, or contact us at thecurbsiders@gmail.com. A special thanks to Martha Brucato for help with this episode, and to the social media team, Hannah R. Abrams on Twitter, Beth Garbitelli on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I've been Dr. Justin Burke.
I've been Dr. Matthew Frank Watto.
And I remain Dr. Paul Nelson Williams, and goodbye.
We send a citation for your CV. This is an open access publication.
Awesome. All right.
This, I think, is really going to open up new doors for your career.
Yeah, I'm sure it will. You guys are hilarious.